Hello, I'm Hans Prenen. I'm at ASCO 2026 and I've just heard the positive survival data from the RASolute 302 trial in previously treated metastatic pancreatic cancer, as well as data from the breakthrough trial in BRAF mutant colon cancer and the EMERALD-3 study in HCC. I will be discussing what it means for our patients and how it will affect your clinical practice. For decades, scientists have tried to block RAS. It's the most common oncogene in human cancer, and it seemed impossible. However, the last couple of years, drugs have been developed either targeting a specific mutation within KRAS, for example G12C or G12D, but also drugs that target RAS in general, such as Daraxonrasib. It is selective for the active state of both mutant and wild-type RAS, and is the first RAS inhibitor evaluated in a large randomized trial for patients with pancreatic cancer, a deadly disease where RAS is known to be an oncogenic driver. In this second-line trial, Daraxonrasib outperformed standard chemotherapy, nearly doubling median overall survival from about 7 months to more than 13 months in patients with or without an identified RAS mutation, which is one of the most significant advances in recent years for metastatic pancreatic cancer. And it led to a standing ovation by the audience. I fully agree with the discussant Dr. Knox that targeting RAS is a game changer for pancreatic cancer. The breakthrough phase 3 study evaluated treatment with the BRAF inhibitor encorafenib plus cetuximab with or without chemotherapy, compared with chemotherapy with or without bevacizumab in first-line metastatic BRAF V600E mutant colon cancer. Following the 2025 breakthrough publication in the New England Journal of Medicine that established encorafenib, cetuximab and FOLFOX as a new standard of care in this setting, the final results of PFS and OS in cohort 3 using FOLFIRI as a backbone was presented at this ASCO meeting, and it showed clinically meaningful and statistically significant results for both overall response rate, PFS and OS for encorafenib cetuximab plus FOLFIRI compared to control, thereby giving clinicians the flexibility in choosing the chemotherapy backbone in combination with encorafenib and cetuximab. Finally, the EMERALD-3 study evaluated whether adding dual immunotherapy, so the STRIDE regimen with durvalumab and tremelimumab, and the multi-kinase inhibitor lenvatinib to chemoembolization could improve outcomes for patients with embolisation-eligible unresectable HCC. You might remember that the EMERALD-1, which was published in 2025, showed that adding durvalumab and bevacizumab to TACE improved outcomes. EMERALD-3 goes a step further by bringing the STRIDE regimen and lenvatinib into the TACE setting, and it showed an improvement in PFS, suggesting that intermediate stage HCC may be treated with combinations of local regional therapy and systemic therapy rather than TACE alone. Thank you.